Okay, good morning everyone, and welcome back to Semel Grand Rounds. For today's session, if you have a question for the speaker, you can use the Q&A button to submit it at any time, either during the presentation or afterwards during the Q&A. Also, please remember to check your email after the presentation ends to fill out a survey for CMA credit. As always, you can visit our website at semelgrandrounds.com to view the upcoming schedule and to watch recordings of past presentations. And now I'll turn it over to Dr. Strauss, who will introduce this morning's speaker.
Good morning and welcome to Grand Rounds for July 21st. It's a great privilege to introduce my mentor, colleague, and friend, Michael Gitlin, who today will be providing us with an update on treatment-resistant depression. As many of you know, Dr. Gitlin is Distinguished Professor of Clinical Psychiatry here at UCLA and has played an important national and international role in the development over the last 4 decades of the field of mood disorders specialization, with emphasis on bipolar disorder and treatment-resistant depression. Upon liberating himself from New York and Philadelphia, Dr. Gitlin began his psychiatric career here as a resident at UCLA in the late 1970s and has remained connected to our research, clinical, and educational community ever since. As a valued academic colleague, Dr. Gitlin has partnered with eminent scientists both on this campus and elsewhere in projects and scholarship. An incomplete list of Dr. Gitlin's research collaborators, which is a measure of his interpersonal gifts and the broad sweep of his intellect, includes Bob Pasnow, Connie Hammond, Keith Nectarline, Lori Altschuler, Vicki Hendrick, Michael Bauer, Mark Fry, George Bartzokas, Carrie Bearden, Joel Yeager, Kay Jameson, David Miklowitz, and many others. In addition to more than 160 peer-reviewed papers, Dr. Gitlin is the author of or co-author of 5 textbooks on psychopharmacology and related topics, including most recently, The Essential Guide to Lithium Treatment with Michael Bauer. Dr. Gitlin is also a beloved and treasured teacher. He's received a number of awards from the Department of Psychiatry and the David Geffen School of Medicine, including the coveted Dadone and Leonard Tao Humanism in Medicine Awards. Michael's also a skilled and capable administrator who has, with great distinction, directed our adult division since 2003, our practice plan since 2007, and the behavioral health component of our UCLA campus student health insurance program since its inception. Generations of UCLA psychiatry residents have rotated through the mood disorder clinic, which Michael co-founded with Kay Jameson in 1985, and which he has directed without interruption for the 35 years since. Beyond the sheer numbers of patients who have been cared for there, another way to measure Michael's impact on our field and its local practitioners is to observe how many psychiatrists have formed supervision groups that return to the campus or now via Zoom to present their complex cases to Dr. Gitlin for his wise counsel, generally at some early morning hour when the rest of us are still asleep. His energy and enthusiasm are, in the best sense, infectious. I too relied on Dr. Gitlin for help during hard times. I've sent a number of my most challenging patients to him for that magical combination of his personal warmth and confidence, and for suggestions about how to modify treatment plans to help patients and their worried treaters do better. Those of you who have trained in or practiced in Southern California know that Dr. Gitlin is the go-to person for complex consultations for our patients who are not doing well. Which brings us to today's topic, an update on treatment-resistant depression. We're all in for a treat and for rigorously vetted new information that will make us all better doctors. It's my pleasure to introduce Dr. Michael Gitlin.
Thank you, Tom. So I hope you can see my screen. Yeah, that looks right. If it's not, please let me know. So the topic today indeed is treatment-resistant depression. And the 2 things I want to say, first of all, thank you, Tom, for that lovely introduction. It was embarrassingly kind of you. So the question is, what do you say about treatment-resistant depression at this point? Let me give you the take-home messages. Towards the end, we'll talk about all the new razzle-dazzle stuff, the stuff that's new and funky and creative, including ketamine, including TMS, vagal nerve stimulation, etc. But the real message is twofold. 1, if you do the basics right, you are going to be way ahead of the game. The fact is, most psychiatrists are not systematic enough in the way they use antidepressants. And if you're just systematic on the basics, you're going to be a star. The second point is that we can't make everybody better. with depression or most other disorders, frankly, and that therefore one of the issues that we have to grapple with as clinicians who treat depression is how do we help our patients deal with depressive symptoms that don't seem to go away no matter what we do. The idea that we can make everybody all better is just naive and incorrect. And I think we have not been honest with ourselves at how to confront that. So with that in mind, well, I'm going to try to go systematically through how you think about it. So first, the question, of course, is always how do you define treatment resistance? And our field, in fact, has no consensus definition. Duration is not the answer because you can be chronic and untreated. Obviously, the number of treatment trials is the center of the answer. But when you take a history, and we go over this all the time in the mood clinic, you can't just listen to a patient and say, oh, yeah, I've been on all those meds. You have to find out, were they adequate treatment trials? What dose did they get to? How long did they take it for? Patients often will say, oh, I took this drug and it didn't help, when the answer is they took it for 48 hours, didn't like the side effects, or just didn't like being on meds, and stopped it. That's not treatment resistance, that's treatment intolerance. Third issue is, do you think of treatment resistance in the same way if somebody's failed 3 SSRIs versus an SSRI, an SNRI, and Wellbutrin as an example? Very few papers really look at that. And then we have the critical issue of what's the goal of treatment? How do you define the end goal? Is it response, which I'll talk about in a minute, or remission? And we'll go over all of those. So this is from a review paper from 11 years ago that looked at all the studies of treatment-resistant depression that had been published up till then and showed how the definitions were insanely varied across them. As you can see, between 6 and 19% for each of the different kinds of definitions. And in 1 in every 5 studies, they didn't even define it. So when you read a study that talks about treatment resistance, you actually don't know what are those patients like, how do they relate to the kind of patients you have. Third, what are the predictors? How do you know who's likely to be problematic? Well, one is they have higher baseline severity or they've been ill for longer. That's a prediction that says this is going to be more difficult. Early onset of illness correlates with 2 issues. Genetic load correlates with onset of illness, and therefore the earlier ones are the more genetic, maybe the more severe ones, but early onset also could relate to bullet 4. One of the reasons that depression is not as genetic a disorder as bipolar disorder is even if you're not genetically vulnerable to depression, if you have serious abuse and neglect in childhood, you're more likely to get depressed, it's likely to come on sooner, and you're more likely to be treatment resistant. So either of those could explain the early onset. The surprise is this one. It's not obvious to me why comorbid anxiety, and I'm not talking a little anxious, I'm talking about powerful anxiety or panic symptoms, why that correlates with treatment resistance, but in fact, in every study it does. Number 4 is childhood abuse or neglect, and it doesn't seem to matter what form of abuse we're talking about, whether it's physical, psychological, sexual, they all predispose to depression and to responding less well to antidepressants. And the last one is lack of social support. The fact of the matter is, depression can be purely biological, but often it's in the context of a life. And people who have more supportive, more benign lives tend to respond better to antidepressants than people who have difficult lives, ill relatives, conflict within families, financial situations, etc. So again, I alluded 2 minutes ago about what is the goal of depression. Well, one possibility is response. Response is defined as a 50% improvement in your depressive symptoms. Every study, every pharmaceutical study uses that definition, but that's not good enough. So if your Hamilton depression score is 28 and you go into treatment and now it's 13, you're 50% better, but at a HAM-D of 13, you still feel crappy and you're still going to be functionally impaired. Remission is a much better criterion. Remission is below the depression score, below a certain threshold, and It's typically the Hamilton score of less than 7 or the parallel on the IDS, the MADRS, or whatever rating scale you're using. And then people feel reasonably well. And this is where that issue of how much better do you need your patient to be before you say, you know what, let's not continue to futz around. Let's not add another medicine, subtract another medicine, etc. And it's a very difficult issue. You can play this game for a long, long time. And sometimes one has to say, and this is a clinical judgment decision, that this is as good as the patient is going to get, and therefore we have to help them now learn to deal with it, called the chronic disease model, analogous to the endless disorders in medicine where the chronic disease model dominates. Things like asthma, diabetes, lupus, arthritis, any of the diseases that are recurrent or chronic. We have not confronted ourselves on that in our field nearly as much as we should. Something else to look for that will help predict someone who doesn't get a full response is how well they've gotten better, or rather whether they'll have another episode, is how much better they got from the prior episode. This is one of many studies that the green line is remission, the yellow line is response. People who respond 50% better but don't remit have a much sooner and higher likelihood of relapsing than those people who are in a remission state, meaning they've gotten all better. By the way, the exact same thing is true with bipolar disorder. So the goal of treating an episode as best you can is to make people as all better as you can, because if they are all better, they're much less likely to have a subsequent episode sooner. So that's an important thing to look for. But even patients who meet remission criteria, virtually all better, Hamilton score below 7, most of them can still have some mild residual symptoms. There's a study from Mass General of people who were remitted. They called it full response, but the definition is remission. Only 1 in 5, looking at depression scores, were truly asymptomatic. The other 82% had at least some symptoms. Which symptoms did they have? They were most likely to have residual sleep and fatigue symptoms. Now, you might say, yeah, but if you gave them antidepressants, you could have fatigue or sleep problems as a side effect. But they went back and looked at the original symptoms that the patients had, and these were the dominant symptoms before treatment also. And I think that's right. I think that fits with at least my clinical experience of patients who get better from their depression. They feel mostly back to normal. They're functioning at a reasonable level. And they say, I just feel like I just don't have the same energy as everybody else. They have this subjective fatigue that is almost like a trait marker for lifetime depression. Or they say, I don't know what's the matter with me. I always seem to sleep I need 9 hours a night, or I'm a terrible sleeper. And this is even when they're well. So it could be that sleep disturbances and fatigue are trait lifetime markers for people with depression. So a diagnostic checklist for somebody who's treatment resistant is: 1, did you get the diagnosis correct? The obnoxious thing I say to residents is and occasionally to patients, is these are not anti-miserables. They're antidepressants. Antidepressants do not cure all that ails humankind. And since virtually all psychiatric disorders are characterized by dysphoric mood, we got to make sure we got the depression right. Does the patient have a subtype of depression that requires other treatments? I'll show you that on the next slide. Are there comorbid medical disorders that affect treatment outcome? Parkinson's disease, certain other things, hypothyroidism. Are there comorbid psychiatric disorders that, in fact, we talked about last year in Grand Rounds, that affect treatment outcome? Borderline personality disorder, untreated substance abuse, etc. And again, is the patient in a toxic environment? Remember, difficult lives predict poorer responses to antidepressants. So for most depressions, all antidepressants are created equal under God's eyes. And that would be a reasonable way to think, with these 3 exceptions. There are 3 subtypes of depression, that need either a different treatment or one type of antidepressant treatment and not another. One is psychotic depression, depression with psychotic features, delusions and hallucinations, mostly linked to depressive things. I'm a terrible person. You should go kill yourself. I caused the war in the Middle East. Things are rotting in my body. All those are mood congruent features. People with psychotic depression do better with antidepressants plus antipsychotics or ECT, and do not do well with antidepressant monotherapy. Atypical depression, characterized by mood reactivity, do you feel better if something good happens, plus hyperphagia, hypersomnia, unusual rejection sensitivity. Those people do better with serotonergic antidepressants versus non-serotonergic antidepressants. And the third is winter depression. And yes, even in Southern California, we have winter depression. We have a clear circumannual variation in our light-dark cycle, much more than in our temperature cycle. And in Southern California, not as much as in Alaska or Boston or Seattle, we find it's very clear that a subgroup of people start to get depressed in October, November when the days get shorter, and light therapy, 10,000 lux light box, half hour in the morning, actually can work with or without antidepressants. So if you have somebody who's not better, you have 4 conceptual options as to what to do. And they are in the field called optimization, switching, combination, and adjunctive treatments. Switching is obvious. Combination, you're adding a second antidepressant. Adjunctive agents, you're adding a second agent that in and of itself is not an antidepressant, but it helps the antidepressant work. So what's optimization? Optimization means you take the medicine that the patient is on and you do something funky or unusual with it. You either use unusually high doses or you give it for a longer period of time. And I'm going to go over for the next little while all of these options. So the first is optimization. Does it help to increase doses from standard doses? And the answer is, shockingly, for most studies, find none. No, that does not help. This is a Cymbalta duloxetine study, but there are absolutely parallel studies with fluoxetine Prozac, paroxetine Paxil. In this study, as you can see, you take patients with depression at week 6, those who didn't get better from 60 milligrams, standard dose, then get re-randomized at that point, now double blind, to continue on 60 or to switch to 120. And as you can see, the response rate is identical. So higher doses are not always better than medium doses with most modern antidepressants, despite what we have this fantasy about. This is the best meta-analysis on this topic. They looked at 9 studies of patients who, after 3 weeks of not getting better with SSRIs, had their dose bumped up from 20 to 60 of Prozac, from 50 to 150 of Zoloft as examples. And as you can see, with an effect size of 0.08, there was no evidence that raising the dose was better. And yet, what does every doctor do if your patient doesn't get better from 40 of Prozac? You bump them up to 60. Why? Tradition, because it's tradition. We always like to raise doses. In practice guidelines, the only practice guidelines have acknowledged that higher doses are probably not better in groups of people are, for obscure reasons, the Dutch depression practice guidelines. Who knew? But the Dutch are the only ones who said, look, if you have failed 20 to 40 of Prozac, move on. Don't raise the dose. And this just shows you, this is another meta-analysis that shows the same thing. So let me move on. All right, so the second part of optimization is time. How long should we give an antidepressant to work? Classically, it's 6 weeks. There are some studies that suggest that people continue to get more better beyond that. The STAR-D data, which was the biggest algorithm-driven study in depression that we've had, 2,900 patients, half primary care, half psychiatry. UCLA was a site, Harvard General was a site. And phase 1 was citalopram, Celexa, mean dose 42 milligrams for up to 14 weeks. And again, there's no control condition. These were not treatment-resistant patients. And this is when people met remission criteria. That's the red bar. And it turns out that 40% of patients met remission between week 8 and 14. Well, what does that mean? Now, again, there's no control condition here, but what that means is that people continue to improve from week 6 to 8 to 10 to 12. Now, this is at variance with what we know from controlled studies. This is a meta-analysis of studies where they looked at how long it took till patients basically asymptoted to their antidepressants. And as you can see, by about week 8, this line, you pretty well got what you were going to get. There's a little improvement from 8 to 12, but not a whole lot. So the answer is 6 weeks probably is enough. That would be this line. 8 weeks certainly suffices. Waiting longer than that, I would not recommend. Second option beyond optimization, we talked about switching. So the question is, again, is it worthwhile switching after a few weeks? And there are a total of 4 studies that have looked at it systematically. The only concern about this is a meta-analysis of the 4 studies, is they use 2 weeks as the cut point. That is, if you didn't respond in 2 weeks, what would happen if you then switched to another antidepressant versus staying on the same medicine? And the answer is, it didn't seem to matter at all. No difference in efficacy for response or remission. Meaning, go on a medicine, give it a full trial. Back to my original comment, do the basics well, and you're a star, relative to not doing the basics well. So if we're thinking about switching, we need to know a little bit what our options are. As I always look at the slide, I think it's always good to see my friends again. Here are my 32 friends, 6 SSRIs, like 9 tricyclics, 4 MAOs, 4 SNRIs, etc. I put this, don't forget, the youth of today don't use MAO inhibitors much, and they are critical options for treatment-resistant depression. We have all seen patients who have not responded to other agents and have responded beautifully to MAOs. So, does it matter if you're going to switch an antidepressant, whether you switch within class, one SSRI to another is the classic, or switching across class from an SSRI to bupropion, an SSRI to an SNRI? Here is the single biggest and most well-quoted study in this regard. This was, again, part of STAR-D. This was phase 2. They took 700 plus people who didn't get better from Celexa after 14 weeks and randomly assigned them, not blindly, but randomly, to Wellbutrin, Zoloft, and Effexor, across class, within class. The remission rates weren't similar. They were identical. There was no reason to think that this would be true, and I find this anti-intellectual, but it's probably true. You're just as likely to get better from a second SSRI after failing a first one as you are if you switch to another class like Effexor, an SNRI, or Wellbutrin, bupropion. Now, I thought, well, maybe it's just that study, and then an adolescent depression study found the exact same thing. So for now, you can assume that if you fail one SSRI, using a second one as drug number 2 is a perfectly legitimate thing to do. Nobody's ever studied if you fail 2 SSRIs, whether you should prescribe a third. That just seems inelegant. I wouldn't do that. I don't do that. Then you might want to ask, if you're talking about single drugs and switching and adding, should we be using, let's say, combinations of antidepressants from day 1, not for treatment-resistant people, but for patients, they come in, they haven't been on anything, why not give them 2 antidepressants in day 1? There were 2 early studies from French Canada, a psychiatrist named Pierre Blier, who suggested that if you take non-treatment resistant people and gave them 2 agents versus 1, they would more likely to get better. Well, it was a great idea. This is the single overwhelmingly largest study in the area, 665 patients, done by the STAR-D group, where they compared Lexapro versus Wellbutrin plus Lexapro versus Effexor plus Remeron, monotherapy, combination. Look at the data. not a shred of evidence that combinations are better than monotherapy for non-treatment resistant patients. So the answer is, just as we've always been doing, we should continue to always do. We start with one drug and we add a second only if needed. So when we talk about adjunctive agents, adding things to the antidepressants, there are a number of ways you can think about this conceptually. One is boosting the function of the neurotransmitter system. So you have a patient on an SSRI, they don't get better. You think, well, they still need more serotonin. How you would know that is obscure to me, but that's what you think. So you'd add a second medicine that augmented serotonergic function. Mirtazapine, Remeron, an antidepressant. Buspirone, that's serotonergic. Lithium is mildly serotonergic. Or you say, bullet two, you say, you know what? I've given serotonin a chance. Why don't I now bring in another neurotransmitter, norepinephrine, dopamine? And so then I would add something like bupropion or a dopaminergic stimulant like Adderall or diamphetamine or methylphenidate, etc. And the third way of thinking about it is you say, you know, leave me alone with those neurotransmitters. Just tell me what works. Here are the 5 first-line agents, adjunctive agents. And again, we don't have time to go over them in detail. Lithium has 11 double-blind studies. It works as well when added to SSRIs as they do to tricyclics. American psychiatrists tend not to use lithium. The Europeans and the Australians and the New Zealand people mock us for that. They see us as kind of little kids who like shiny new toys, and lithium is not shiny or new, and they mock us for not using it. So be it. Cytomel, T3, triiodothyronine, a thyroid medicine that at low dose in people who have normal thyroid function may augment the antidepressant effect. T4, L-thyroxine, doesn't seem to work. Combinations where you add a second antidepressant to a first. The data aren't great, but we do it pretty regularly. Stimulants, which are the opposite of lithium. So lithium, the database is great and no one prescribes it. Stimulants, the database is awful and everyone prescribes it. Everybody loves stimulants. A little dopamine will do you. And the data in support of stimulants as adjunctive agents is weak, but we use it all the time in the mood clinic. Now, whether that reflects that people just like the way stimulants make them feel, or there's a subgroup who really have this slow down, anergic, hypersomnic, fatigue, depression, and they have unique responses to stimulants is unclear. Far and away, the largest database are the second generation antipsychotics, whether it's Abilify, Rexulti, Vraylar, Seroquel, etc. The database here is bigger than all the other 4 combined times 5. And that's, of course, because these were patented agents when the studies were going on. So pharma firms did a lot of good studies on second generation antipsychotics, and they all work. But remember, second generation antipsychotics are still D2 blockers. They confer risks with the exception of Geodon, Ziprasidone. They confer risks of weight gain, metabolic syndrome, some of them, and tardive dyskinesia, all of them. So we need to treat second generation antipsychotics with respect. As a clinician, you're not thinking about whether to prescribe an adjunct or a placebo. You're looking to decide, do I prescribe this additive effect or that additive effect? There aren't that many good comparison studies. There are 2 studies, however, this happens to be one of them, which compared adjunctive bupropion to adjunctive aripiprazole or Abilify, probably the 2 most common adjunctive treatments in the United States. And stunningly, in both studies, aripiprazole was somewhat better than bupropion. That happens to fit with my clinical experience, but it's impressive that there are 2 studies now showing that Abilify is simply slightly more effective than Wellbutrin when added to an SSRI or an SNRI in the face of treatment resistance. So that's something interesting. Second line agents, and again, we don't have time to go over them every one in detail. There are a bunch of things that have been tried. Buspirone, the anxiolytic, lamotrigine, the mood stabilizer, Pindolol is a beta blocker that has pro-serotonergic effects. Then there are the natural substances, omega-3 fatty acids, St. John's wort, SAMe, and L-methylfolate. I want to show you the lamotrigine data in a moment. The moment is here. So everyone loves lamotrigine. It is the only mood stabilizer that has no weight gain. And if you don't get this dreadful rash, which is about 1 in 6,000 people, it's astoundingly well tolerated. However, the data for lamotrigine for unipolar depression is dreadful. Here are the first 2 unpublished studies on it. This is for unipolars, not bipolars. And see if you can find any room between the lamotrigine line and the placebo line. It's really hard to tell. So I do use it occasionally. I think there's a small subset of unipolar depressed people who do respond to lamotrigine, but my goodness, the database in support of it is just awful. Even the data on lamotrigine as an adjunctive agent, this is the largest study from Jim Barbie at LSU, 183 people add lamotrigine after they failed 2 antidepressants, and it just didn't work. So here too, from a data viewpoint, lamotrigine is a loser, and nonetheless, every clinician I know, including myself, seems to find a handful of unipolar depressed patients who really seem to do better with lamotrigine versus placebo. Let's never forget ECT, still the gold standard treatment for treatment-resistant depression. It's classically 6 to 12 treatments given 3 times weekly. There's a study from Israel showing that if you give it twice weekly, it takes longer because, right, it takes more weeks to get the same number of treatments, but it's just as effective and fewer cognitive side effects. There are lots of technical issues around ECT, which have to do with lead placement, bilateral, unilateral, and voltage considerations that predict both efficacy and the cognitive impairment, which is what everyone worries about. And we have a very vigorous ECT service at UCLA, which, as somebody who runs a mood clinic, I am so grateful for, because ECT is extraordinary. Who's likely to get better from ECT? There have been a number of meta-analyses. This is the most recent good one. Surprisingly, what it shows is psychosis is indeed a mild predictor of a better ECT response. Older people, a mild predictor, maybe severity, and that people who respond to ECT, bipolar depressed people, do just as well as unipolar, and women and men are equally likely to respond. One of the things you never want to see in the mood world, Lord knows I never want to see, is somebody who failed ECT. It's like you play the best card in your hand, and now what? You're still not winning the game. So the question about what do you do with ECT-resistant depression is a critical issue. Our database is virtually non-existent. I show you this study because it's one of the few where they actually compiled one strategy for treatment-resistant depression. Now, I must confess to you that I've given MAO inhibitors to people who have failed ECT and seen them respond with some regularity, not all the time, of course, but regularly enough that I do that routinely. This was a study from, I think, Spain. They took 31 patients who had clearly failed ECT, and they gave them a combination of a tricyclic amitriptyline, Elavil, and tranylcypromine, an MAO inhibitor, Parnate, and used that in combination at a reasonable Elavil dose and a high Parnate dose. Now remember, this is an open study, so you don't know whether these people would have done just as well with Parnate alone. Still in all, 80% response, and 3/4 of them continued well for 9 years. Even in an open study, that's an impressive outcome. And we do know, officially you're not supposed to, but it's clear that you can indeed combine tricyclics and MAO inhibitors safely by either starting them together or adding the MAO to the tricyclic. And in this group of N of 31, they had no hypertensive episodes, consistent with other data in this area. So this slide should be a talk in itself. What else can you do after first and second line agents? And my goodness, I could have put 4 or 5 other things on here like pramipexole. We're going to talk about ketamine in a moment. We're not going to talk about high dose thyroid, but there's a paradigm on using 4 times the usual dose of thyroid, vitamin D, exercise. Exercise, the data are moderate for treatment of, but actually better for prevention of. People who exercise are less likely to get depressed. There's a small literature on deep brain stimulation. We'll leave that for another time. And acetylcysteine. I'm going to talk about whole body hyperthermia in a minute. Testosterone. Dr. Jen Cruz and Mike Irwin in our department are experts on the relationship between inflammation and depression and the potential use of anti-cytokines that cool down inflammation for treating some depressions. Opiates, which have a bad name right now, but there is probably a small subgroup of people who actually do well with even Suboxone as an antidepressant. And again, we don't have time to go over the details today. I wanted to talk about whole body hyperthermia, not because I've ever used it with patients, but because it's an example of something that you say, wow, this is really not just a Me Too treatment. This is really different. And this was done in the group that was run by a former UCLA resident, Chuck Raison, for those of you who remember him. Anyway, who would have thought of this? Take 34 depressed people and you warm them up. You give them infrared light to make them febrile up to about 2 hours. And the sham group got lights, but it didn't heat them up. And amazingly enough, they got better. Now, again, it's a small study, but it did have a control condition. But I thought the idea of basically roasting people to make their depression go away was such an extraordinary idea. I just thought you needed to know there's still creative people in our field. All right. Obviously, ketamine is now the darling of the treatment-resistant resistance world. In depression, it's an NMDA antagonist. I say maybe because it's not clear that that's the mechanism by which it works. The first studies were slow push intravenous over about 40 minutes, 0.5 milligram per kilogram. And there was no doubt that it worked. And there was no doubt that it worked amazingly quickly. Within 1 day, people got somewhat better. Not everybody, but when it worked pretty quickly. And then its isomer, Sketamine, got released and approved by the FDA, called Spravato, as an adjunctive treatment in treatment-resistant depression. And it, too, has good data. Sketamine is an intranasal administration. So you snort up your Sketamine, one in each nostril. There's a dose response. Higher doses clearly have better efficacy. You can see the data there. The data look just like ketamine, and the side effects are just as you expect. Nausea, vertigo, and dissociative phenomena are the big thing. People get really loopy, which is why they can't drive for the rest of the day. If they get it in the office, which is the classic Sketamine approach, they can't drive home. That's not acceptable. They don't get psychotic. They get loopy and sleepy. And one of the nice things in this area, there's the beginning of the data showing that not only do people get better from Sketamine, but you can keep them on a continuation and a maintenance treatment, which will continue to provide efficacy. This is a study published a year ago, and you can see that the data go up to about 1.5 years. The classic paradigm for either IV ketamine or intranasal ketamine or Spravato, which is only intranasal, is generally twice a week administration for 4 weeks, once a week for 4 weeks, and then you start spreading it out as you would after ECT. When you go for maintenance ECT, you gradually try to spread it out to once a week, then every 2 weeks, hopefully once a month. Because of the NMDA effect of ketamine and Sketamine, there's been a reasonable amount of preliminary work on using other medicines that affect the NMDA receptor system to see if we can keep the ketamine and esketamine effect going, so we don't have to keep giving people ketamine and esketamine. Every one of those studies has failed. So right now, the only paradigm that we have for people not relapsing after a short course of ketamine or esketamine is to continue the ketamine or esketamine in gradually more and more infrequent administrations. And this is the only study I've been able to find that's a year old comparing ketamine to esketamine, and it really looked like it was basically the same efficacy. And if you really look at the effect sizes, the drug placebo differences, it looks like esketamine and ketamine are equivalently effective. The one issue, the one area that is still under some dispute is, could you give ketamine orally? So if you imagine that intravenous ketamine is absorbed 100% because it's given IV, intranasal ketamine is absorbed at about 50% the rate, and oral ketamine is poorly absorbed. You only absorb about 20% of it. So if it's 20% of the IV, you would imagine it should be 5 times the dose, 20% times 5, to get the same effect orally. Well, it's very interesting that in the best recent study, this is from the British Journal about a year and a half ago, the Domani study from Israel, they did not give, remember, 0.5 milligrams per kilogram is the classic IV dose. Well, then orally it should be 2.5 milligrams per kilogram. In this study, they only gave 1 milligram per kilogram. That should not have been enough. And they had efficacy that looked just like the IV studies. The time to onset was pretty clear, was pretty similar. It lasted the same amount of time. It was not what anyone expected. So I don't have a good way of understanding why it is that oral ketamine was used at a lower dose and with the same efficacy. But I think that's intriguing, and it's one of the things that a group of us, Jen Cruz, Andy Luchter, Tom Strauss, that when we set up our ketamine service, which we're in the midst of doing, we are thinking of using it as an oral preparation, given partly this study. Anyway, interesting stuff. Other things to consider, other neuromodulation treatments are RTMS, which I'll show you a slide or two on, vagal nerve stimulation, and TDCS, which probably doesn't work so well. So for TMS, we have, I think, the best TMS service in the city, started by Ian Cook and Andy Luchter, and now run by Dr. Luchter. And originally the thought was it wasn't helpful for treatment-resistant patients. It was only helpful for people that only failed one treatment for depression. Probably not true. More recent studies after the FDA approval and tons of clinical experience show pretty clearly that if you take people with 2 or more antidepressant treatment failures, a reasonable definition for treatment resistance, people get better with nice number to treat numbers of 5 and 9. It works. Vagal nerve stimulation, which is very hard to get because it costs about $30,000 to $35,000, and even though it's FDA approved, not a single insurance company will pay for it. It was approved in 2012 or so, and 3 years ago, they published a follow-up on the original group that had it, and they found, this is months, so this is 2 years, this is 3 years, this is 4 years, that the people who had the vagal nerve stimulator in them, and it's like a pacemaker. It's a little box, and you regulate it through a wand, through a computer. People continued to get more better over years. Remember, this is 3 years. The asymptote is between 3 and 4 years. I think that's really interesting, but it's so hard to get because of the price. And it really does involve putting in, it's a surgical procedure to put it in, whereas TMS is so much easier. The reason this is very relevant, why we have all these options and we continue to try to find others. So what happens if you don't use something interesting? Despite what I said before about get the basics down and you're a star, this is the group from the vagal nerve stimulation study who didn't get VNS. So these are treatment-resistant depressed people who were treated as per whatever their doctors wanted to do in the community. 124 of them. They were treated for 2 years, just however the doc wanted to. These are about the most depressing, I use it with pun intended, response and remission rates I can imagine. Of these 124 people, only 1 out of 124 remitted from whatever else they were given and stayed remitted by 2 years. 1 in 124. The fact is, if we don't keep trying, people don't get better. And that's a serious thing to say. All right. I have not talked about psychotherapy in this talk because there are other people who know way more about it than I do. For years, the mantra was always, oh yes, in depression, meds plus therapy works better than either one alone. And the data showed that that wasn't true. That meds work, that therapy works, and meds plus therapy didn't work any better than either one alone, like 1 + 1 = 1. Finally, 3 months ago, the first meta-analysis looked at the series of studies and, oh, thank you, finally came up with an answer that said that combination treatment, meds plus therapy, was better than either one alone. For years, that had been the mantra without good enough data to support it. And now you can tell your friends and your neighbors and your family members that it's true. And they found it was even true for treatment-resistant depression. So I think that's critical. Okay, my last data slide, and then we'll wrap up. Remember I said, if you do things systematically well, you're going to really do much better. This is from a study from Michael Bauer, a friend and colleague. He was here at UCLA for a number of years. This was an inpatient study because in Germany, they can actually keep people in hospitals so they get better. What a novel approach. They took people with depression and they just did a systematic course of treatment, sleep deprivation, antidepressant, high-dose antidepressant, lithium, MAOs, ECT, etc. It didn't matter to me what the algorithm was. What mattered is it was an algorithm, and they had a systematic approach. And what they showed, SSTR is the algorithm. This is TAU, treatment as usual. And what Michael showed is that a systematic approach was more effective than just having docs do what they do. And that's not because these are bad docs. It's hard to be systematic. You have to really work at saying, was this long enough, etc. The idea being that systematic approaches are more effective than non-systematic approaches. So let us wrap up with, so here's the trick. Do the basics well. Remember, these are antidepressants, not anti-miserables. So don't imagine that antidepressants are going to treat everything. Make sure that you gauge the efficacy of the trials and don't accept the patient saying, oh yeah, I took that, it didn't help. Get the details. Use consistent, thoughtful algorithms. The new and expensive techniques, like, well, TMS and ketamine are new and expensive. ECT is an old, expensive algorithm technique. Use them in the appropriate places in the algorithm. And remember, you're not going to make everybody better. And so one of the things that we need to do, and again, our field has not confronted this as much as it should have, is we need to work with our patients to help them live with being mild or moderately depressed. We may not be able to make everybody all better, but we can make 90% of them at least somewhat better, and then use health habits like exercise, psychotherapy, to help them go from kind of moderately depressed to mildly depressed. And again, the concept of the chronic disease model, helping people live with some depression, just not as bad as it could be in its extreme version, is something we need to do more and more. So remember, first make sure you check your diagnosis, be systematic. Please don't forget about MAO inhibitors. That's a critical part of an old treatment that I think really works beautifully. Remember adjunctive treatments and our newer friends, well, ECT is the new friend, it's an old friend, our new friends, TMS and ketamine. And if you just are systematic about this, you'll be a star. All right, thank you. And we'll take some questions now.
All right, thanks so much, Dr. Gitlin. We have a few questions from the audience. So we'll start with a question. How do you approach re-challenging a patient with an antidepressant that they've used in the past, either one that was ineffective or effective? Is it worthwhile? Is there any consideration being, in terms of their present psychosocial situation being different?
So mostly, if somebody had a failed trial of one agent, mostly we don't try it again, just because it's unlikely to work. Now, there are no good data on this. What's interesting is the concept of what do you do with a patient who got better from an agent, then the agent seemed to lose its efficacy. The person became tolerant to it. You take them off. It's now a few years later. Might you have reversed the tolerance so you can now try it and it works again? There are no good data on this. Everybody I know has tried it. Every once in a while it works, but it's an inconsistent approach. I think that's worth trying. If they didn't get better from a prior trial of antidepressant A, I wouldn't use it again. But if they develop tolerance and now they've been offered for a while, that's reasonable to try.
Okay, thank you. We have another question about ECT. So last year, the residents went over a paper about how ECT was economically efficient after 2 failed medication trials. The question is, how many medication trials are being attempted these days before trying ECT?
I don't think there's a good answer for that because it depends. Some patients are eager to use ECT given how extraordinarily effective it is. But culturally, as we know, with movies like One Flew Over the Cuckoo's Nest and Francis, ECT has a bad reputation. So it's rarely the doctor that makes that decision. So it seems to me we should be using ECT in two circumstances. One, if somebody's really seriously, catastrophically ill and they can't work and their life has ground to a stop. Or if their life continues, but they have failed multiple agents. They failed 7 or 8. The more severe they are, the more you move ECT up into the algorithm because it's a much quicker way of getting people better so they can go back to their lives and function and have relationships and all that.
Our next question is, how early in the process is it most helpful to work with patients to accept that they may have chronic mild symptoms?
That's a terrific question for which I don't have a terrific answer. I would say not too early, because I think early on, it's still legitimate to think that we might actually be able to make people all better or put them into remission, which is probably the right way to put it. But it also seems to me that the longer it goes on, the more you need to think, well, maybe we won't be able to get you all better, which I think is really true with primary care docs, let's say in arthritis. If you try a whole bunch of things, you don't tell them after you just give them a little ibuprofen, well, you may hurt forever. You wait until you've tried a bunch of things, and if not, you say, okay, how can we make you as well as we can and figure out other ways of making this more manageable? So I think that's a clinical judgment call.
All right. We have a question about your view of antidepressant use in BPD, which I'm not sure if they're referring to bipolar disorder or borderline personality disorder, but I would actually be curious to hear both.
Well, the antidepressant in bipolar disorder, I think I gave that as grand round 6 months ago. I think BPD here refers to borderlines. And so let me answer that question. So we know from studies that 85% of borderlines will meet criteria for major depression at some time in their life. And of those 85% of them will have recurrent episodes. So borderline patients tend to get depressed. We know that antidepressants do less well in the face of significant personality pathology like serious borderline personality disorder, but you wouldn't necessarily not use it. There's a whole other field like what's the psychopharmacology of personality disorders? What would you use to treat them in general? And that's something that's worthy of a longer discussion. It really involves more anticonvulsants and antipsychotics than antidepressants. But certainly, do I use antidepressants with with borderlines, of course I do. I just am aware that it's not going to make their borderlininess go away. It'll take care of some acute symptoms.
All right. We have another question. Can you talk about how to handle non-adherence in treatment-resistant depression patients, either people who stop medications or resist taking them in the first place?
I assure you that if I had a great trick, I would let you know it. This is one of the great problems. Patients who come in and every time they've gone off antidepressants, they've gotten depressed. And they know that about themselves. And they still go off. And you say, what were you thinking? And they say, you know, every time I think this is the time I could go off it. It's like, what's that line about second marriages? The triumph of hope over experience. It's the same thing here. It's just, and all you can do is use supportive and cognitive techniques to try to help them see what's obvious to all of their relatives and to you as their treating physician. I wish I had a magic trick for that. I promise I'd let you know.
Thank you. Another question. Would you ever revisit a medication that had failed prior to ECT to see if it works status post-ECT?
If we're thinking about using the medicine now as a maintenance treatment to prevent relapse after successful ECT, yes. One of the problems, we don't really know after successfully effective ECT, if you're not going to have maintenance ECT, which medicines should you go on? Because usually these are people who have been on a whole bunch of things before ECT. Can you then use medicines that they fail to respond to, but now will keep them better once they are better? And anecdotally, that does seem to work. I can tell you after effective ECT, my rule is you go on 2 agents, whether it's 2 antidepressants, an antidepressant plus an antipsychotic, an antidepressant plus a mood stabilizer. I would not put somebody on just a single antidepressant. You have to be more vigorous in your preventive treatment after ECT.
Okay. All right, and then last question. My sense of the data suggests that the dissociative response of ketamine predicts the antidepressant response. What are your thoughts on this, and if it extends to oral versus IV versus nasal administration?
That's interesting. If that's true, I'm not aware that that's consistently seen. That you have, the more dissociative you get, the loopier you get, the better you get. I don't know that that's true, so I don't think I have a good thought on that.
Okay.
Sorry.
All right. No worries. Well, there's definitely a lot of questions left, but in the interest of time, we're going to go ahead and wrap up. But I think that just shows how much interest there is in this topic. So I just wanted to say thank you so much for taking the time out to review your knowledge and expertise on this. And yeah, we very much appreciate it.
Thank you.
All right. Thank you, everyone, for joining. Have a good rest of your day.